Hi, very good evening. Today we have this textbook discussion on the topic selection of abutment teeth from a reference. We have this textbook reference Rosensteil. So I've shared the pictures of the information in a Google group. So I hope you have gone through it, and if possible, you would have taken a printout of it, right? So we'll just have textbook discussion on the same topic, and we'll just go through the entire text, and after that, before we conclude, we even have some MCQs to discuss on the same topic, right? So we'll break the session into two if possible. So in the first part, we'll just have the entire textbook discussion, and in the second part, we'll go through the summary of the entire text as well as MCQ discussion, right? That's what I'm planning to do in this session. So very good evening once again. So it's a beginning of a week. I hope you're all more energetic and enthusiastic. Hi Srish, Abhishek, hi Rupali, hi Megha, Ramesh, Shivani, hi. Hi Saida, hi Swati, hi Prithvi, hi Regina. Hello Ashutosh, yeah, hi Ashina. Yes, again Ashina and Gina. Yes, Niharika, hi, very good evening. Hi Komal. Yeah, hi Sahiti. Yeah, Regina, I've done that this morning itself. While I was going through the text simultaneously, once I completed, I shared the text to Google Groups. Hi Stuti, very good evening. Hi Preeti. Hi Anuja. So we'll start off right away with textbook discussion. It's going to be an elaborate session, so let me do it as fast as possible, right? So I'm following third edition of Rosensteil, chapter 3, treatment planning, page 65. So selection of abutment teeth. So whenever possible, FPDs should be designed as simple as possible. The design has to be simple because if not, the steps are going to be more elaborate. It's going to take more time as obvious, and also the prognosis again can become more challenging. So the design of FPD has to be as simple as possible. So whenever possible, FPD should be designed as simply as possible with a single well-anchored retainer, fixed rigidity at each end of the pontic. And today's topic is selection of abutment teeth. The use of multiple splinted abutment teeth, non-rigid connectors or intermediate abutments or pair abutments makes the procedure much more difficult, and often the result compromises the long-term prognosis as we discussed now. So let's see, while different criteria for selection of abutment teeth when we are replacing a single missing tooth or when we're trying to replace multiple missing teeth, right? So there are numerous criteria. In the process, we're going to collect as many important points as possible from the text. So coming to the first one, that is replacement of a single missing tooth. So as you can see here, Unless bone support has been weakened by advanced periodontal disease, a single missing tooth can almost always be replaced by a 3-unit FPD having one mesial and one distal abutment tooth. And I request you all to pay attention while we're going through, because we're going to have various multiple choice questions from the same. I've created various multiple choice questions from the same text. So if you can pay attention, then it will be easy for you to grasp the concept, and also it will be very easy for you to answer the questions later on comparatively in a simplified manner possible without any ambiguity, right? Yeah. So unless bone support has been compromised, in a normal case scenario, when a single tooth is missing, then a 3-unit FPD would be an ideal, and in that circumstance with one mesial retainer and another distal retainer, right? And an exception, we always have exceptions for general rules, right? So exception is when the FPD is replacing a maxillary or mandibular canine. Under these circumstances, the small anterior abutment tooth needs to be splinted. That is, the lateral incisor needs to be splinted with the central incisor, because canine takes up lots of load. It has longest root in the entire oral cavity. So when you're trying to replace canine, it can be the maxillary canine or mandibular canine. We need to take the support of not only the mesial lateral incisor but also the anterior central incisor, right? So that's very important. So this is in regard to a replacement of single missing tooth. So we have different criteria, and also have something called as concept of cantilevers. So we'll go through that now. Cantilever fixed partial denture. So cantilever is nothing but where you have support only on one side. For example, we'll just go through the text. FPDs which only one side of pontic is attached to a retainer are referred to as cantilever, right? And for example, if you're trying to replace, he's given the example here itself. Lateral incisor pontic attached only to an extracoronal metal ceramic retainer on a canine. So when you're trying to replace the lateral incisor, it's a small tooth. So if you have support from canine, it's a distal canine, that would be sufficient, right? So these forms a best example for a cantilever FPD. So their use remains popular because some of the difficulties encountered in making a 3-unit FPD are lessened, obviously, and also many clinicians are reluctant to prepare an intact central incisor, preferring instead to use a cantilever, right? So cantilever FPD is an FPD where the pontic is attached only on one side. The best example would be when you're trying to replace the lateral incisor, maxillary lateral incisor, where you take support only from the canine rather than from the central incisor, which is present mesially. Now, however, the long-term prognosis of a single abutment cantilever is very poor, because forces are best tolerated by periodontal supporting structures when directed along the long axis of tooth, and this is possible when you have a 3-unit bridge, right? However, in case of cantilever, so a cantilever will induce lateral forces on the supporting tissues, which may be harmful, and there can be tipping, rotation, and drifting of abutment tooth. So design itself will lead to tipping, rotation, or drifting of its cent tooth, and you can look at the images which are given in the text. Let me just show you the images. Yeah, figure 316, as we can see here. So when you apply horizontal force as well as when you apply vertical force, you can see the tipping movements, because you have the support only from the canine but not the central incisor. So there can be lateral forces acting on the abutment tooth, thereby leading to either tipping, drifting, or rotation forces. Right? So if you have a 3-unit support, then obviously all these forces can be tolerated very well, as the forces will be directed mostly towards the long axis of a tooth. Right? So that's the main drawback or challenge we have with a cantilever design, right? Yeah. Now, laboratory analysis has confirmed the potential harmful nature of such fixed partial dentures. However, clinical experiences with resin retained FPDs has suggested that cantilever designs may be preferred, especially since re-adhesion after failure is greatly facilitated and often leads to predictable long-term success. So even though we have this challenge, it is clinically acceptable as per various studies. Right. Now, try to highlight this particular point and note down if possible. Cantilevers are indicated in cases where you're trying to replace maxillary lateral incisor, and also cantilevers are indicated in cases where you're going for implant supported processes, and also when you're trying to replace multiple teeth, multiple teeth with multiple abutments, obviously you're going to have a lot of support from various multiple abutments. So this cantilever design can be incorporated when you're replacing a lateral incisor, when you're replacing implant supported processes, and also when you're replacing various multiple missing teeth where you have multiple abutments, right? So when multiple missing teeth are replaced, cantilever FPDs have considerable application. The harmful tipping forces, which we discussed previously, are resisted by multiple abutment teeth, and the movement of abutments is unlikely. Cantilevers are also successfully used with implant supported processes. So these are three clinical situations which were given here where you can go for cantilever design. This is very important, just make a note of that. Now, after going through cantilever design, now let's see assessment of abutment tooth, right? So when you're trying to assess abutment tooth, we have to evaluate its clinical status, not just the periodontal status, but also the pulpal status. We observe it clinically, we observe the radiographs, we observe the periodontal status. So all that has to be done thoroughly because periodontal support is very much essential in order to enhance long-term survival of any tooth. That's obvious, right? It's like a foundation. So assessment of abutment teeth, radiographs are made, pulpal health is assessed, which is very important. We have to go even for dermal tests, electrical stimulation to see how the tooth is responding normally. Teeth, this is important again. You can see teeth in which pulpal health is doubtful should be endodontically treated before initiation of fixed process. Instead of going for IPC or DPC, direct pulp capping or indirect pulp capping, whenever you have a doubt or question over the pulpal status of a tooth, it's better to go for root canal because if you go for capping and then you go for a bridge, what if there is later some exaggeration of the lesion or there can be again a clinical problem? Then in that case, the entire bridge is going to get wasted, right? So whenever there is a question in prognosis of a tooth in regard to the pulpal health, it's better to go for intentional root canal treatment followed by processes. So teeth in which pulpal health is doubtful should be endodontically treated. Although conventional endodontic treatment is normally preferred for cast restorations. So that's understood. Now, this is how we basically go before we start selecting abutment teeth. So assessment of abutment tooth, not just endodontically or periodontically, but also both endo-perio assessment and also to check clinically the status of a tooth. And also most important, if you have any question regarding the status of pulpal health, go for endodontic conventional root canal treatments, right? Now, endodontically treated abutments, do you think they are fit to act as abutments? Yes, they are, because even though they are endo-treated, even though the strength seems to be compromised, clinically, they are found to be fit provided we have adequate structure of crown as well as root. So endodontically treated abutments, if a tooth is properly treated endodontically, it can serve well as an abutment provided you have this post and core foundation for retention as well as strength. Remember, post and core assets do not contribute to resistance, but trying to obtain retention from a post to a particular core. So if a tooth is properly treated endodontically, it can serve well as an abutment with a post and core foundation for retention and strength. Failure, however, particularly on the tooth with short roots or little remaining corneal tooth structure can happen. Care is needed to obtain maximum retention of post and core. Sometimes it's better to recommend removal of badly damaged tooth rather than taking the benefit of doubt and going for this cast restorations, right? So if it is badly broken, grossly decayed, better go for extraction. If you think you can save it based on the remaining crown structure, go for a post and core to reinforce the tooth, and then we'll go ahead with this cast restoration. So endodontically treated abutments are also fit to be used as an abutment, endodontically treated tooth we're talking about. Next, coming to the most important aspect, unrestored abutments. In fact, clinically sound tooth is an ideal tooth to act as an abutment, and it's given clearly that an unrestored caries-free tooth is an ideal abutment. So that's obvious, right? We all know that. It can be prepared conservatively for strong retentive restoration with optimum aesthetics. The margin of retainer can be placed without modifications, all that's fine. Certain patients are reluctant to have perfectly sound tooth cut down to provide anchorage for a fixed partial denture. So if a patient might say you're going for FPD, then you're trying to reduce my natural tooth or the decent normal tooth, I would not accept that. Then the onus lies on the operator to explain to the patient that just don't worry about one tooth. We are talking about the overall health of you. It's not just one tooth you're talking about. You're talking about oral health, which in turn influences the overall health. That's how we should orient the patient, and that's the same stuff given here in the literature as well. And even if you remember the definition of operative dentistry, it's given in one part of definition that ultimately it should enhance the health and welfare of the patient, right? So it's not just one tooth we're treating, we're trying to address the entire patient as a whole, right? And it's given that certain patients are reluctant to have a perfectly sound tooth cut down to provide anchorage for FPD. In these cases, the overall dental health of the patient should be emphasized rather than looking at each tooth individually, right? So that's a general statement. Now, coming to most important aspect, in cases where you have these tilts. So when you have these tilted teeth, so how do you go for selection of abutment? Do you think tilted teeth can be used as abutment teeth? So we have certain criteria for that in order to correct the tilt, or we can modify the design of processes to incorporate the process in that particular area. We'll just go through that now. So mesially tilted second molars, loss of a permanent mandibular first molar. Always remember, whenever there is a loss of a tooth and when you don't replace it, there can be tilting of its teeth, there can be supraocclusion of the opposing teeth, and as a result of tilting and drifting of the teeth, there can be loss of contact. So these are some of the sequelae that tend to happen when you don't replace a missing tooth. That's very important. So loss of a permanent mandibular first molar to caries early in life is still relatively common. And if the space is ignored, the second molar will tilt mesially, especially with eruption of third molar, and it then becomes difficult or impossible to make a satisfactory fixed partial denture because the positional relationship no longer allows for parallel paths of insertion without interference from the adjacent teeth. So when you're designing a wax pattern, when you're designing a crown, you should have this most important aspect, that is parallel path of placement and removal to facilitate placement of a crown, isn't it? So whenever you have a tilt, it's obvious that we don't have this parallel path of orientation because of the tilt, right? So in such circumstances, an FPD is sometimes made with a modified preparation design or with a non-rigid connector or a straightforward solution that is trying to upright your tilted tooth, either by using a removable appliance or a fixed appliance. Usually we use a fixed appliance, or we can go for orthodontic uprightening or even surgical correction, right? So we have different options in these circumstances when you have a tilted tooth. We can even go for a modified preparation, or we can even go for a selection of a non-rigid connector where you have a male and female components, or a straightforward solution may be considered, that is uprighting the tilted orthodontically, uprighting the tilted abutment orthodontically using a simple fixed appliance. However, the problem can be avoided altogether by giving a space maintainer. So once there is a problem, then yes, tilts could be done. Once you have this tilt, you can modify the preparation, use a non-rigid connector, or you can even tilt or upright the tooth orthodontically, or if at all there is loss of tooth, then immediately you can prevent the migration or drifting of teeth by giving a simple stabilizing appliance, which is given in the figure 319. You can see a square orthodontic wire which is fixed using some restorative materials, and this prevents the drifting of teeth and thus protects the contacts or preserves the integrity of its tooth contacts as well. However, this simple stabilizing device cannot prevent supraocclusion, which is very, very important, right? So these simple stabilizers do not prevent supra-eruption of opposing teeth. And remember, this device may be seen, okay, eventually it's anchored with small restorations at the center. So this is how you address this mesially tilted teeth, right? So this mesial tilting of a second molar is accentuated by the eruption of third molar and is commonly seen because of loss of mandibular first molar, right? Now, so far we have seen the criteria when you're trying to replace a single missing tooth. We had discussed about the cantilever design, we had discussed about assessment of abutment teeth, and also the role of endodontically treated tooth as abutments and what is an ideal abutment all about. And finally, we had discussed about a mesially tilted second molars. Now let's go through what if there are multiple missing teeth. So what are the factors which we need to consider, and most importantly, what is this Antes law all about, right? We'll just take a 1 minute break and then go through your comments and then come back to discussion once again. Yes, hi Nidhi, a very good evening. Yes, Regina. Ashutosh, you can just join our group. I've shared the link of our group. You can join our group and you'll get access to the material as well, right? Yeah. Hi Pooja. Hi Novali. Hi Devna. Neetu. Hi Sadhana. Hi Najni. Hello. Hi Alvin. Anu. Ben is hi. Hi Nidhi. Hi Nidhi Singh. Yes, Bernes. Agreed. And hi Pinky. Hi. Hi Karanjit. A very good evening. Hi Tanu. Hi everyone. Yes, Prithvi, already I mentioned that we'll be having a summary of the entire discussion and then MCQ discussion simultaneously in another separate session today itself, right? Yeah. Okay, I hope you're doing good. Yeah, hi Solomon. Glad to see you again. Okay, right. So we'll continue with our discussion then. So replacement of several missing teeth. So in cases where you have several missing teeth, how do you go for selection of abutment teeth? Yeah. Fixed prosthodontics becomes more difficult when several teeth must be replaced. Problems will be encountered when restoring a single long uninterrupted edentulous area or multiple edentulous areas with intermediate abutment teeth. And underestimation of the problems involved in extensive prosthodontics, which can lead to failure. Okay, one key to ensure a successful result is to plan the processes by waxing the intended restorations and articulated diagnostic casts. When you're planning for multiple units, processes, then it's better you have this diagnostic cast, make a mock-up, then try to estimate, and then based on that we proceed. And remember, this key to ensure a successful result by planning a processes is by waxing the intended restorations on articulated diagnostic casts. This is essential for complex fixed prosthodontic treatments, particularly where an irregular occlusal plane is to be corrected, or when the vertical dimension of occlusion VDO is to be altered, or an implant supported prosthesis is recommended, and a combination of FPD and RPD are to be fabricated. In these cases, we go for this wax mock-up, or we have this waxing of intended restorations or those teeth which are planning to replace in a diagnostic cast setup, right? So these are the four criteria mentioned here. One is when you're having this irregular occlusal plane, or when you're trying to correct the vertical dimension of occlusion, or when you're planning an implant supported processes, or you're planning an FPD and RPD simultaneously. In these cases, we have this diagnostic wax setup, right? And then we'll plan our treatment accordingly so that the prognosis would be better comparatively. And also, there can be something called as overloading of abutment teeth in cases where you're planning to replace multiple tooth, right? Multiple teeth. So the ability of abutment teeth to accept applied forces without drifting or becoming mobile must be estimated and has a direct influence on prosthodontic treatment plan. If you remember, we discussed already that most of the forces will be traveling along the long axis of the tooth, and that's the best mechanism through which forces can be dissipated effectively and efficiently. But when you have this cantilever design or certain designs, or in cases where you're planning for replacing multiple teeth, there can be drifting forces, there can be lateral forces acting on different abutment teeth, which can have unwanted effects like tilting, drifting, or even rotation, or even there can be damage to the periodontium of these abutment teeth. There can be potential damage. And The forces can be particularly severe during parafunction habits like grinding, bruxing, or clenching. Okay, so that's what is mentioned here. Not much information is given, which is relevant for us. Next, coming to direction of forces. The magnitude of any applied force is difficult to regulate. A well-fabricated FPD denture can distribute the forces in a most favorable way, directing them in long axis of the abutment teeth, as we already discussed. Potentially damaging lateral forces can be confined to anterior tooth, where they are reduced by the long lever arm. If you remember, we have this concept of lever and fulcrum. The longer we are from the fulcrum, the lesser the effort is needed in order to create that kind of effort. So these lever principles and all we have beautifully represented in Rosensteil itself in one chapter, along with schematic representations. You can go through that, or you can even Google where you'll get class 1, 2, and 3 different lever principles, which is very simple to understand along with illustrations, right? So direction of forces, usually they are along the long axis of tooth. Of course, there can be potentially damaging forces, like which include lateral forces that can be damaging to the periodontium as well as to the abutment teeth. So when you have this drifting, tilting, or tipping movements, it's because of the damage that's happening to the periodontium as such. Now, most importantly, we have something called as Ante's law, which has something to do with a root surface area. So Ante has proposed this theory where he mentioned that the pericemmental area of the abutment teeth, that is the supporting structures, should be equal or greater than the pericemmental area of the teeth which you're going to replace. So this is Ante's law. For example, if the pericemmental area of Preeti, exactly. If the pericemmental area of the tooth which you are replacing is X, then the pericemmental area of the abutment teeth has to be minimum of X or greater than X. So that's Ante's law. So Ante has suggested this law in 1926. The root surface area of potential abutment teeth must be assessed for planning the treatment for FPD. And in 1926, Ante suggested that it was unwise to provide a fixed partial denture when the root surface area of the abutment was less than the root surface area of a teeth being replaced, and this has been adopted and reinforced by many authors. So we have these average values of root surface areas. They're mentioned in the table 3.1, page number 71. So they're given the percentage root surface area in quadrant and also the root surface area in millimeter square. So you just go through the values, need not memorize any of them, but you can see which has highest and lowest. In maxillary teeth, you can see we have lowest pericemmental area for maxillary laterals, which is obvious, and we have highest pericemmental area in case of first molar. Pretty easy to remember. And in case of mandible, the lowest pericemmental area is for mandibular central incisor, which is again obvious, and the highest pericemmental area is for your first molar, which is around 431 mm², right? So these are some of the values. So you have a question on these values. Okay, I haven't seen. Now, can you share that question, Abhishek, if possible, or if you can just vaguely give the idea behind the question? Are they asking the values, or is it a comparative kind of question in regard to the pericemmental area values? Because as such, absolute values are really impossible to remember. Okay, right. Okay, let me know if that question. So Ante's law, we have this pericemmental area. If values, then okay, then memorize that. That's it. It's simple for me to say. Yes. Okay, we have these values given in table 2.1. Okay, they've asked the values of first molar. So obviously you can remember for, in case of maxilla, remember for maxillary lateral and maxillary first molar, since it has lowest and highest values respectively. And lower mandibular arch, central and first molar, which have lowest and highest respectively. Okay, right. Good, good. Fine. Okay, thank you. You can just go through the values here, right? Yeah. Yeah, in case of first molar, it's 431. Mandibular first molar. Maxillary first molar, it is 433. Right. And thanks for letting me know. and also try to have this comparative analysis, right? So that's pertaining to Antares law. So you can just skip the remaining part, right? But however, various other authors have proved that even though if you don't follow Antares law, the health of periodontium can be maintained by meticulous root planing, by meticulous oral hygiene and all. So all that is not too relevant for us. Now, coming to, and also we have one important statement given here. Antares law is something which decides the prognosis of a given bridge. Antares law is useful for determining the prognosis of fixed partial dentures as you're trying to evaluate the pericemental area or root surface area of an abutment teeth. And coming to root shape and angulation, this is quite interesting, easy to remember, and also we can just have a comparative analysis, and definitely we can expect a question from these things because often we get confused between two options. So here you go. Now, root shape and angulation. When a tooth support is borderline, the shape of roots and their angulation should be considered. So, as such, the shape and angulation are secondary, but even though they're secondary, they do have that secondary influence. So, when tooth support is borderline, the shape of roots and their angulation should be considered. A molar with diverging roots, obviously, you have this tripod effect, or when you have these diverging roots, so more or better or enhanced support than a converging or conical morphology of roots. So, a molar with divergent roots will provide better support than a molar with conical roots, and little or no interradicular bone, right? So obviously when you have these diverging roots and conical roots, so diverging roots you'll have more support comparatively. And in case of a single rooted tooth, an elliptical cross section will have better support than a tooth with similar root surface area but a circular cross section. So when you compare a single rooted tooth with elliptical cross section and circular cross section, elliptical cross section you'll have better support than circular cross section. And similarly, well aligned tooth will provide better support than a tilted one. So you're trying to compare a normal upright tooth and a tilted tooth. So obviously a well aligned tooth will allow the flow of forces along the long axis. So it provides better support than a tilted one. And alignment can be improved with orthodontic uprighting as we discussed previously. So root alignment and angulation we discussed in case of multi-rooted teeth, multiple divergent roots or converging conical roots. In case of single rooted tooth, you can have this elliptical cross section versus conical cross section, and also well aligned tooth versus a tilted tooth, tilted abutment tooth, right? And then coming to role of periodontal disease. After horizontal bone loss, this is very interesting and very important, and you can go through that in figure 323. We'll just go through the text first. After horizontal bone loss from periodontal disease, the PDL supported root surface area can be dramatically reduced. Because of the conical shape of most of the roots, this is very important, please pay attention. Because of the conical shape of the most roots, when 1/3 of root length has been exposed, it's not 1/3 of support that's being lost, but half the supporting area is lost. In addition, the forces applied to the supporting bone are magnified because of greater leverage associated with lengthened clinical crown. Thus, potential abutment teeth need very careful assessment when significant bone loss has occurred. It's very simple. Just go through these images here. You can see in this case you have normal bone support. Here you have loss of bone support, right? So when 1/3 of bone support is lost, half of the root surface area is being lost, because since this is a conical shaped root outline or morphology, you will have more of the root surface area here, right? So even when 1/3, generally what we expect when there is 1/3 loss of bone, we expect only 1/3 loss of support, but that's not the way that's happening here. When only 1/3 loss of bone occurs, more than half or half of the support has or is being lost in the process because of the orientation of the roots, conical orientation of the roots, and also most of the root surface area is present on the coronal aspect of the entire root, right? And on top of it, when there is bone loss, you can see the clinical crown length is more or greater than this anatomical crown length. So because of greater or increase in clinical crown length, more forces act on the abutment tooth. Clinical crown is something which is visible clinically, whereas anatomical crown is something which extends from the incisal edge to your CEJ, incisal cusp tip to your CEJ. So in case of recession, obviously the clinical crown is greater than anatomic crown. That's obvious, right? I hope it's clear. So in cases where there is bone loss, just remember these 2 points. When there is bone loss, for example, as mentioned here, in cases where there is horizontal bone loss, when 1/3 of root length is exposed, more than half of the supporting area is being lost because most of the bulk of the crown or most of the bulk of the root is present on the kernel third as well, right? Because you have this conical orientation, so when 1/3 of bone loss is there, most of the support, that is half of the support from root is being lost. And most importantly, due to this bone loss, because of recession and all, the clinical crown length increases, where as a result of which more and more forces act. Because of compromised periodontium, even a normal force becomes abnormal in that context, particular context, right? I hope we have discussed that in TF4, trauma from occlusion as well. So this is an important consideration. So care has to be taken when you're evaluating teeth, abutment teeth, especially with those having horizontal bone loss, right? I hope it's clear. You can just go through the image also. It's made much more simpler. Horizontal bone loss can be deceptive, as given in the legend. A little can result in a considerable loss of bone support because of the root morphology, right? I hope it's clear. Healthy periodontal tissues are a prerequisite for all fixed restorations, which is very, very important. Now, we have penultimate topic, that is length of the span of bridge or span length. Like based on number of missing pontics, you have this length of the bridge, right? So we have one formula also here, which has a correlation between the length of the span of the bridge as well as the amount of flexing that happens because of the forces acting. We'll just discuss that now. So in cases where there is long span FPD, long span fixed partial denture, there can be excessive flexing under occlusal loads. And it can lead to fracture of a porcelain veneer, breakage of connector, loosening of retainer, or unfavorable soft tissue response, and thus render a processes useless. And remember, this is very important, you can just make a note of it. All FPDs flex slightly when subjected to load longer than the span. And remember, so all FPDs are subjected to flexing. And the longer the span of the bridge, the greater the flexing. And also the relation between the deflection or flexing and the length of the span is not linear. It means if the length increases by 2 units, deflection increases by 8 units. If the length increases by 3 units, deflection increases by 27 units. So we have this not linear relation but cube relation, in the sense the deflection of a fixed partial denture is proportional to the cube of length of its span. We'll just go through that again. This is very important. There is nothing to get confused about. So the deflection, so we have a relation between deflection and length of the span. It's not linear. I mean, if length increases by 1 unit, the deflection doesn't increase by 1 unit. So we don't have this linear relation. We have this cube relation, in the sense the deflection of a fixed partial denture is proportional to the cube of the length of its span. Let's see how it goes. When other factors are equal, if the span of single pontic, so when you have only a single pontic or a single span FPD, when a single pontic is deflected by a certain amount, a span of 2 pontics will deflect 8 times more than the previous one, and the span of 3 pontics will move 25 times over the previous one. So when the span of the pontic is only 1 unit, it deflects by some X units. When the span of the pontics or span of FPD is 2 units, so it is 2 cube. So it deflects 8 times compared to the previous one, that is 1 unit. And when you have the span which is around 3 pontics long, then the deflection is going to be 3 cube, 27 times greater than that of the first instance which we discussed, right? This is very simple. A single pontic will deflect a small amount, for example, D, when subjected to a certain force. Please pay attention. A single pontic will be deflected to a small amount by D. 2 pontics will deflect by 8D by the same force, and 3 pontics will deflect by 27D by the same force, right? So the deflection is proportional to the cube of the length. That's the only thing you have to remember here, right? Only one sentence. The deflection of an FPD. So this is an FPD, it gets deflected under load. gets deflected under load, and this deflection is proportional to the cube of the length of the FPD. That's it, right? Now, anyways, we'll have MCQs. We can just clarify if at all we have any questions over there. And replacing three posterior teeth with an FPD rarely has a favorable prognosis, and especially in a mandibular arch. You just keep this in mind. Replacing three posterior teeth in case of a mandible, it has poor prognosis. Under such circumstances, either go for implant supported processes or removable partial denture, right? And when long span FPD is fabricated, pontics and connectors should be made as bulky as possible to ensure optimum rigidity without compromising the gingival health or jeopardizing the gingival health. And in addition, the process should be made of a material that has high strength and rigidity. That's it. Now, finally, so that's pertaining to selection. When you're trying to replace multiple teeth, these are some of the criteria which you should consider, like the span length, direction of forces, shape of the roots, angulations, etc. And when you're going for replacing multiple anterior teeth, so you tend to have mostly lateral directed tipping forces, mostly in case of anterior teeth, since they are away from the fulcrum. And also remember, mandibular incisors, because of their small size, generally make poor abutment teeth, as we have seen in that perisegmental area value. So mandibular centrals have very low, and there's very low capacity to support an FPD, right? And for example, you're trying to replace 4 anterior teeth, mandibular anterior teeth, then you can take support of mandibular canines on either side. But if you have one central, mandibular central in between, it's better to remove that and then go for or plan for a FPD, rather than retaining the natural missing or natural central incisor and going for an FPD. Because if you have only one mandibular central in between, your canine, then the design of your process becomes more and more complex. So in order to minimize or in order to simplify the design, it's better to extract that lone standing mandibular central or lateral and then plan for an FPD canine to canine on the lower aspect. And remember, mandibular incisors, they are poor abutment teeth because of their low perisegmental area comparatively. And also because of curvature of the maxillary arch, forces directed against a maxillary incisor pontic will tend to tip the abutment teeth. So we have more of tipping forces in case of anterior teeth because of the arch design as such, because of the curvature of the arch. And also it's given that tipping forces must be resisted by means of 2 abutment teeth at each end of a long span anterior FPD. This is very important. So these tipping forces, which can be generated in case of anterior teeth, must be resisted by not 1 but 2 abutment teeth, especially when you're designing a long span FPD in cases where you have these missing teeth, right? Long span FPDs. If only one mandibular central incisor is missing, then obviously you can take the support of the adjacent teeth, right? The lateral as well as the other central and lateral. I think that would be sufficient. Yeah. And also we have these ridge defects. So ridge defects can be enhanced by ridge augmentation. However, the prognosis is questionable, or we can even go for planning of RPD, right? So these are some of the criteria which are given in cases when you're planning for replacing multiple anterior teeth, right? So in case of lower incisors, they are mentioned about the mandibular centrals and laterals, which are very poor, perisegmental, very low poor, not poor, but low perisegmental area. They given some criteria for replacing teeth there. And in case of maxillary arch, you have this curvature, which tends to have these kind of tipping forces, which have to be overcome by using 2 abutment teeth anteriorly as possible in case of long span FPDs. And also when you have ridge defect, either because of periodontal disease or because of trauma, as can be seen here, it's difficult to correct that ridge defect with your crowns, because crowns are not going to replace your supporting tissues, right? Moreover, in patients with high smile line, this ridge defect will be visible clinically when you go for FPD. So in such cases, it's better go for a removable partial denture, where you can cover off that defect with an acrylic, a gingival acrylic, or even we can plan for this surgical procedure, that is ridge augmentation, right? So these are some of the criteria mentioned here. And for me, deflection is nothing but some kind of inward movement which we see with respect to long span FPDs. Just remember, deflection is proportional to the cube length of I mean, the length of the cube length. In the sense, deflection will be 3 times with every increase in the pontic length. For example, as I mentioned previously, you have one pontic which is missing. So in case of an FPD, the length of an FPD, we measure that in terms of missing teeth, right? So if it is a one pontic which is missing, so you have one pontic scenario, two pontic scenario, and three pontic scenario. In case of one pontic scenario, if the deflection is X units. In case of two pontic scenario, the deflection is going to be 8X units. In case of three pontic scenario, the deflection is going to be 27X units, right? I hope it's clear. So with every increase in the length of the pontic or length of your FPD, the deflection is going to be increasing 3 times. 3 times in the sense cube, right? I hope I made myself clear. You still have any doubt? We have one question pertaining to that. So in the process of solving it, definitely you will have much more clarity, right? Just remember one thing, deflection is proportional to the cube of length of the FPD, right? Hi Dimple. Hi Pooja, very good evening. Yes, we have seen the values also, right? So you have any questions, I'll just wait for a few minutes and then we'll break. We'll break and we'll have a summary of all that we discussed so far, and then we'll go into MCQ discussion. Hi Rina, a very good evening. Okay, you have any questions, just let me know. It's been 46 minutes. I'll wait for a few more minutes. Yes, we have Ashina, Gina, Regina, and Rina. Right. No, actually, I'm planning to summarize on board because I can't just explain all the components with subheadings here. So I need to use the board. So I'll be summarizing on board. I'll be summarizing on board and then I'll be proceeding with MCQ discussion. Yeah, obviously, when mandibular canine is missing, obviously you have to take the support of the anterior tooth as well as posterior teeth, posterior two teeth, two premolars. Or because instead of disturbing the anterior, there can be aesthetic issues. So it's better you can take the support of the posterior two premolars, in my opinion. Or if it's a maxillary canine, then obviously, as we discussed, we take the support of lateral and central incisor. So obviously, just remember when a mandibular canine or canine missing, we have to take the support of adjacent two teeth on one side. That's for sure. And also go through this table. As you said, we have even values, so you can just go through the table also. Yeah, we had different numbers altogether. Obviously, it's better. I mean, it's better if you can move on to the posterior aspect, because again, anterior aspect, we have to go for minimal preparation of central incisor. So I think I'm not exactly sure because I have never faced that clinically and I have never done a case of a lower canine missing, an FPD especially. So I think the posterior one will be the best. Anyways, I'll just inquire with my prosthodontic friends and I'll let you know. What if mandibular canine is missing? What would be the best replacement option? So what would be the abutment teeth selection, right? So that's a question. Yeah, definitely I'll get back to you with regard to that question. Yeah, in case of maxillary canine, it's clear. We obviously take the support of lateral as well as we take the support of the maxillary central also. In fact, the central and lateral, they're splinted together to have this enhanced support for the canine. So maxillary canine, we take support of lateral as well as anterior. Yes, Prithvi, if you have 3-unit FPD and maxillary canine is present, and mandibular second molar is present. Yeah, exactly, Abhishek. Even I speculate the same. But anyways, I'll just confirm it. Prithvi, I didn't get your question exactly. If you have a 3-unit FPD and maxillary, if you have a 3-unit FPD and maxillary canine is present, and mandibular second molar is present, then it doesn't become 3-unit, right? You mean to say if 3 teeth are missing, like 2 premolars and first molar, is that your question, Prithvi? Try reframing the question again. I didn't get you exactly. Yes, Ashina, why not the posterior? You're talking about the maxillary teeth. Maxillary teeth, lateral surface offers a very poor support, right? So obviously, and moreover, you're going for, in case of missing maxillary canine, you take support of the first premolar and you take the support of maxillary lateral and maxillary central, right? I'm not getting you. Don't mind, just reframe the question again, Ashwina and Prithvi, and try to give that in a single comment, right? Yes, obviously. Yes, Sadhana. In case maxillary canine is missing, we use central, lateral, and first premolar as a teeth for support. Yeah, even I think the same, Rishabh. I think we'll go for cantilever design. Yeah, cantilever pontic also. 3-unit FPD, okay, Bernice. If 3 teeth are missing, then obviously it becomes a 5-unit bridge, right? Units means the number of teeth which you are replacing, in the sense not just replacing as a pontic, but also which covers the retainer, right? So usually we say units, in the sense it encompasses not only the pontic but also the abutment teeth. If 3 teeth are missing, you're taking support of 2 teeth, then obviously it's a 5-unit bridge, right? Which is having a length of 3 pontic span. The length of the bridge is 3 pontic span because you have 3 missing tooth, but you have 5 units altogether. So we call it 5-unit. If 3 teeth are missing, we call it 5-unit. Yes, Ashina, that's what I said, right? Yeah, that's what I said. In case where you have maxillary canine missing, you take support of maxillary first premolar and maxillary lateral, maxillary central. Lateral offers a very, it has low perisegmental area, so you take the support of the central incisor as well, and we splint both central and lateral together. Right. Yeah, unit says total number of teeth involved. Yes. Unit is a general term. If you want to be more specific, you can call it as pontic. You can call that as a retainer. Yes, Prithvi, if you have maxillary first premolar, second premolar, and first molar missing, then should we take support of maxillary canine even if we are taking support from second molar? Uh, Prithvi, if you have maxillary first, second, and first molar missing, you should take support of maxillary canine. Ayyo, how can you design a processes when you don't have this nasal support? You have three units missing, right? You have three teeth missing. You just can't have a cantilever design. Obviously, you need to have support from the anterior canine as well. Yes, we need to have, right? So, to your question, if maxillary first premolar, second premolar, and first molar are missing, we take support from the second molar and also from maxillary canine. If you think second molar has more perisegmental area, and if you don't plan a retainer or process extending onto canine, obviously it fails. Go through the perisegmental area values, right? Yes, Abhishek, you're right. Abutment plus teeth, which has to be replaced, we consider them as units, number of units. That's why I got confused when Prithvi asked me a question regarding when she said 3 unit FPD, and again the span seems to be like total 5 units. Yes, Mega. Do we give FPD in this case? Which case, yeah, if it is a mandibular arch, Mega, that's a good question. It's mentioned that there is poor prognosis if three posterior teeth are missing, but since it's maxilla, and moreover you're taking the support of the second molar and canine, if their periodontal is sound, obviously we can give it a try. I reckon we can give it a try. Yes, it will have a very long span. Abhishek, go through the question again. Prithvi says even the first molar is missing. Third molar we usually don't select because most often third molars are ectopically erupted or we don't get a good support. They are not good teeth for abutment selection because they have this conical orientation, they're not reliable. And moreover, the periodontal maintenance, right? The maintenance of oral hygiene in third molar area, it's quite challenging normally, but when you're giving a process, it becomes even more complicated. I don't think so. We'll select a third molar. Yes. Right. I hope clarified a few of your questions. If you still have any, I'll definitely wait. Okay. Do you want me to break then? It's 10:05. Yes, it's even challenging to prepare a third molar. Right. Yeah, that's what I'm saying. I'll summarize. in the virtual classroom session along with MCQ discussion on board. Then maybe we'll take the support of lateral also, Abhishek. Have you seen the values? Yeah, obviously. Then obviously we'll have to take the support. If it is not satisfying anti-slope, then we'll have to take the support of maxillary-lateral. But remember, anti-slope is not widely accepted. And there are many studies which prove that anti-slope need not be maintained or need not be followed to have a better prognosis for given processes. We even have these statements given in the same textbook where they mentioned that meticulous plaque control, root planing, and good oral hygiene are sufficient to have better prognosis. It's not that we should mandatorily satisfy this anti-slope. Yes, according to anti-slope, it's going to be less. In that case, FPD itself is harming unwanted or unnecessary good tooth. FPD design itself, you're trying to grind the natural tooth, which is sound, right? That's what it's mentioned. It's not a single tooth you're talking about. You're talking about the design of process, the prognosis of it, and also how it's going to impact the overall health of a patient, not just oral health, but also overall health. Anti-slow is good, but even without following anti-slow, there are many case reports where they have shown that with proper periodontal health, one can maintain a process for a longer time. Let me just read out that statement for you. Nyman and Erickson, page 69, however, cast doubt on the validity of anti-slow by demonstrating that teeth with considerably reduced bone support can be successfully used as FPD abutments. The majority of treatments presented by these authors had an abutment root surface area less than half that of replaced teeth. Half that of, less than half. And there was no attachment clause for 8 to 11 years. So they attributed this success to meticulous root planing, proper plaque control during observation period, and occlusal design of the processes. So there is no point for us to discuss all this. So anyways, theory point of view, you can just go through the values, and theoretically you can say whether you can go for such a design or not, right? But clinically, I don't think this will be that relevant. Exactly. Okay. I've never come across a case where for support we cross midline. Even if a lateral is missing, you take support of only central sadhana. But if lateral and canine are missing, then obviously you take this, you go behind posteriorly, taking the support, because clinically you just can't touch. I mean, a normal central incisor unnecessarily, as one of you rightly mentioned, right? So clinically, again, it's all different from what we learn from theory. Because theoretical point of view, that's fine, but clinically, when you're applying it, you have to consider a lot many factors as well. Not just the design, but as one of you rightly mentioned, the economics, expertise of the operator, many factors. Yes, Komal. Yes, that's what I said. Clinically, we do all these kind of variations. We don't follow any of these laws. We just follow one thing, one principle, that is how to earn real quick. The more the units, the more the money you have. Right. Okay, it's 10:10. We'll break now. Again, we'll meet you at 10:30.